Now, today we'll be again talking about one more drug that is dopamine. Now, dopamine is very commonly used in ICUs or intensive care. Now, dopamine is also a dopaminergic or adrenergic drug, and it has marked effect on dopaminergic receptors, which is followed by beta 1 receptor, which is followed by alpha 1 receptor. So, maximal activity is seen on dopaminergic, that is D1 and D2 receptors, then it is seen on beta 1, and then it is seen on alpha 1 receptor. So we must know that this is a natural catecholamine, whereas dopamine is a synthetic catecholamine, and this is the precursor of norepinephrine. So it has activity on dopamine 1, D1, D2 receptor, beta 1, and as well as alpha 1. And it has no beta 2 activity, just like noradrenaline. Noradrenaline also has no activity of beta 2. Now um, when we are talking about this alpha 1 markedly cause contraction or constriction of these arterioles and veins, which causes constriction, vasoconstriction, and which increase the blood pressure. That is the reason why dopamine we use for shock. So whenever there is shock, whenever we intend to increase the blood pressure, we always consider dopamine as one of the agent. This has activity on beta 1 as well. So beta 1, we know that these receptors are seen on heart, and the main aim of this is to increase the heart rate and to increase the force of contraction. So dopamine markedly increase the force of contraction, but that doesn't increase heart rate at a very high level. It definitely increases the heart rate, but at lower or moderate dosage, the force of contraction increases, but heart rate increment or chronotropic effect is compared to lesser. So, as it has alpha 1 activity, it has DO activity, and beta 1 activity, we can utilize this to increase the force of contraction. By that way, we can increase the blood pressure, and we can increase the blood pressure by vasoconstriction of arterioles and veins. We know that this beta 2 receptors, they cause dilatation of arterioles and veins, and it causes fall in blood pressure. That is the reason why this beta 2 activity is not seen with dopamine. That is the reason why fall in blood pressure is not seen. So this dopamine has D1 receptor. This D1 receptor basically, these are plenty of seen in renal vasculature and mesenteric vasculature. So this D1 cause renal vasodilation. That is how it increases the GFR. That is how it causes natriuresis. That is how we try to give dopamine at a lower dose so that to maintain the urinary output. So whenever there is reduced urinary output in shock, we usually tend to add dopaminergic drug, that is dopamine, at a lower dose so that urine flow can be maintained or urine outcome can be improved. At moderately high dose of this dopaminergic drug, dopamine, it has beta 1 activity as well as dopamine 1 receptor activity. It has markedly good positive inotropic action. So, suppose a patient has hypertension, he is already on vasopressin or noradrenaline, then also the blood pressure is not remaining stable or good. If the patient's urine output is less, that time dopamine can be added or it can be additive, because it will definitely assist in vasoconstriction, but it will increase the inotropic activity, which actually is lagging in NORAD and vasopressor or vasopressin. So this positive inotropic activity can be used of dopamine to increase the systolic blood pressure, and it can also definitely cause renal vasodilation, and it can help to have a good urinary output. And it has little chronotropic activity, so at lesser or moderately high dosage the chances of arrhythmia will be lesser, but at high dose definitely the tachycardia, SVT, VT, VFib, these problems can be there, because there will be significantly increased beta 1 stimulation, so there will be tachycardia. And at high dose, there is intense alpha 1 stimulation, intense vasoconstriction, and that is how there will be increase in blood pressure. So we use this dopamine for increasing cardiac output, because it increases the inotropic activity, and that is how it increases the cardiac output. And it is to used for to increasing the systolic blood pressure. So whenever there is hypotension, we can consider adding dopamine. As it doesn't penetrate the blood-brain barrier, The CNS effect of this medicine, like delirium, is not at all there. So dopamine is used for cardiogenic shock because in cardiogenic shock there can be reduced contractility of the heart, there can be hypotension. So to increase the cardiac output so that all the body parts like liver, brain, muscles, kidneys, tendons, everyone should get a good blood flow. This dopamine can be used to increase the force of contraction, to increase the cardiac output, to sustain the blood pressure, and as it has little effect on chronicity, especially at lower or moderate to high dose of dopamine, it can definitely be used for septic shock to increase the cardiac output and to maintain the blood pressure, and in severe congestive heart failure, because in CHF, very commonly heart failure component will reduce the contractility of the heart, and this, as there is reduced contractility of the heart, blood pressure can be poor or patient may have hypotension. So that component will be held by dopamine. This component of reduced contractility will not be held by vasopressin or noradrenaline. That is the reason why it can be used with noradrenaline, vasopressin at lower dose to increase the contractility, to increase the cardiac output, and to increase the blood pressure. So when we call it as low dose, moderate to high dose, and more high dose, we are talking about whenever this dose is less than 3 microgram per kg per minute, we are talking about low dose, which actually increase the cardiac output, which increases the renal blood flow, and which also increase the splanchnic blood flow. 3 to 10 microgram per kg per minute, we call it as moderately high dose. It also increases the contractility. It has minimal effect on heart rate, so the chances of tachycardia, SVT, VT, VFib will be much lesser at this 3 to 10 microgram per kg per minute dosage, and it also increases the splanchnic blood flow. And when we are talking about a very high dose, that is more than 10 microgram per kg per minute, it causes intense vasoconstriction because of significant alpha 1 vasoconstriction. There is marked increase in heart rate, and this will then increase the risk of SVT, VT, VFib, and arrhythmia. And basically, at that time, there will be reduced splanchnic blood flow because of the intense vasoconstriction. The dosage calculation is pretty easy. We can simply suppose if we want to institute 2 microgram per kg per minute, what we can see, suppose we can take weight of 50 kg. So 100 microgram per minute will be the dose if you want to start with 2 microgram per kg dose. So 100 into 60 will be per hour dosage. So that will be like 6,000 microgram, means 6 milligram. 6 milligram of this dopamine infusion per hour. So you simply take 6 milligram, yeah, whatever dose. Suppose if you are taking 20 milligram, 40 milligram of dopamine into 50 ml ns, you simply calculate the 6 milligram. If you are taking, suppose 24 milligram of dopamine into 50 ml ns, so you know that every 12.5 ml of this NS has 6 milligram of dopamine. So you can simply continue this infusion at 12.5 ml per hour, and it will deliver 6 milligram of dopamine per hour. So 6 milligram of dopamine per hour means you are delivering 2 microgram per kg per minute of dopamine to the patient. That's all for today. Thank you.